46. Okay, I'll stop the response now. Okay, it's done. Okay, now we will share the screen. Yes. Okay, can you see the screen over here? Okay. So let's start. Okay. So earlier what we learned in the previous lectures, let me revise it. We learned the we can say antibiotic resistance, how antibiotic gets or how antibiotic develops the resistance. What is the mode of the resistance? What is the mechanism for the resistance? So we all know that sorry. So we all know that there are different types of antibiotic. Uh, if we talk about the starting from penicillin to the latest antibiotics, the mode of action and mechanism of action of the antibiotic is totally different. Some of the antibiotic they act on the cell wall, they inhibit the cell wall synthesis. Some of the antibiotics they act on 30S, they act on 50S, they inhibit the synthesis of protein by interrupting 30S and modulating the 30S or 50S subunit. Some of the antibiotics have a role in plasma membrane, in cell membrane. Some of the antibiotics have a role in DNA replication. Say, for example, the attachment site of the gyrase that leads to the antibiotic resistance. So there are different types of mode of action and mechanism of action, right? So now, what type of care should be taken to avoid the antibiotic resistance, right? Because this is the, we can say the uh, mm, very emerging field for the researchers. Why? Because antibiotic resistance and antimicrobial resistance, we can say antimicrobial resistance, we can say MDR, multi-drug resistance. So these are the terminologies where all the researchers, all the scientists are coming together in the international platform, and they are solving the mysteries that how we can stop the antibiotic resistance, or we can come over to the multi-drug resistance or antimicrobial resistance. So yes, the patients, the clinicians, the scientists, researchers all have to come onto the same platform to solve this mystery. So if we talk about the patient, last time I think we have stopped from here, right? So if we talk about the patients, poor adherence of the dosage regimens, right? So sometimes what we know, we directly take the dose, right? Azithromycin dose, we don't know how much we have to take. Either we are taking very low dosage or very high dosage, and we are modulating by ourselves. We are not taking the advice of any clinician, or we are not following the prescription. Each time, every time we have to go to the clinician, and we according to our symptoms, clinicians will prescribe us the specific antibiotic and the specific dosages, right? But what we are doing, we are directly taking the drug, just we are doing the Google, and we are taking that I should take this, I should avoid this, I should take this, whatever the available in the market or medical store, we are taking this, right? So we are not following the proper guideline of dosage regimens, right? Now poverty is there, yes, obviously, due in India specifically, poverty affects the antimicrobial resistance. Yes, they are not like I mean, I cannot say incapable of, but we can say due to their financial we can say boundaries, or that they are not taking the proper dosage. Lack of sanitation concept, yes, sanitation is mostly required, education is not there. See, we are teaching you, right? You are the budding scientist, or we can say you are not layman, right? So you know that what are the benefits and what are the merits and demerits of taking these antibiotics without prescription or just random use. So the lack of the education that leads to the antimicrobial resistance, that every time some people are taking drugs now and then, right? If today I have a headache, I'll take easily that Flame or any type of drug, right? But no, we should avoid, right? We should not take certain drugs at certain times without asking anybody, without prescription. We should not take. So lack of education is there. Self medication, yes, as I said, we are not visiting the doctors, right? And we are not doctors. Though we are scientists, we don't know the anatomy, physiology. There are many things that we are not knowing, right? So we should avoid. Yes, we know that this drug will work on the specific symptoms, but yes, we are not master in that, right? So we should take advice from any clinician, and properly prescribed drug only we have to take. So we have to avoid the self medication. And please don't advise anyone that you should take this drug or this drug. No, you are not doctor, right? And misconception, obviously. It leading the misconception that okay, in the fever you have to take only Dolo 650. But why you have to take Dolo 650? Why you have to take paracetamol, or why you are taking crocin? See, there is it should be definitely symptom based drugs. We must say that personalized drug is there based on your weight, based on your habits, right? Everything should be monitored. You directly can't take any drug, right? So to stop this, first, patient counseling awareness program should be organized, right? So if we talk about the specially AMR, antimicrobial resistance, all the doctors, they are doing this thing. But yes, patients are more aware about the diabetes, more aware about the cancer, more aware about the AIDS, but they are not aware about the antibiotic resistance, right? That is the really, we can say, big burden. The mortality ratio is very high in antimicrobial resistance. Though patient doesn't know that how we have to take drugs, in what concentration, at what time, right? So patient counseling awareness program should be enhanced, or we can say should be appreciated by the doctors. And yes, we have to motivate the layman that okay, this type of programs are there, you must have to watch and you must have to follow. Now prescriber related, we have seen the part of patient, right? What patient has to do and not patient, they doesn't have to follow, right? Now prescriber, prescriber means it may be clinician, right? And obviously we are not sorry. So what are the different types of, like what is the like prescriber, what they have to follow, what are the rules and regulation for the prescriber? So inappropriate use of available drugs, they sometimes what actually happen, this is routine practice of Indian doctors, that any pharmacology company or an AMR, medical representative, they visit to the doctor's place and they just offer some very good deal to the doctors, that if you prescribe this drug to the patients, we will give you the abroad trip or something like that. So what they will do, if you don't have the symptoms of that specific disease, he or she will prescribe you the specific drug, because of that if increases the sale of the drug, definitely he or she will get the certain benefits, right? So it is inappropriate use, though the patient doesn't require such type of drugs, but just clinician for their benefit, they are prescribing you such type of drugs. So always be careful whenever. So now you are educated, right? So whenever you are checking your prescription, you have to see, okay, you have fever, okay, fine, I will take the drug for fever. If you have cold, okay, fine, I'll take. But you don't have sore throat, you don't have any infection, so why you have to take in antibiotic? No, I'll not use the antibiotic because I don't have any infection, right? Unnecessarily we don't have to give exposure to our body to antibiotics. So now you have to ask to the prescriber or clinician or doctor that why you have prescribed me this antibiotic. I don't have any type of infection, I have only fever and I have only cold, right? So it will be anyhow, it will be, I will be recovered within 3 to 4 days. If I'll not, then I'll come again and we will see whether we have to carry on this antibiotic or not. So you have to make questions to yourself or your prescriber that I am not kid moves and I'll not follow your advice, right? So he or she should know that okay, you are knowing the things. So next time he will not play with you. Increase empiric poly antimicrobial use. So they are randomly giving the means everyone say for example, if you have any eye infection, right? There is an infection in your eye, but doctors, he is a very poor in microbiology, so he don't know whether the infection is gram positive bacteria, whether the infection is gram negative bacteria, whether the infection of fungus, right? So he will prescribe all the drugs, 3 drugs, right? Gram positive, negative, fungal, everything, because he doesn't know anything. So you will be exposed to the different types of drugs, right? So random drugs, increased empiric poly antimicrobial use. Overuse of antimicrobials, same overuse. Once you have followed the dose of azithromycin for 5 days for 500 mg, again, if it is not solved, again doctor, okay, go for the second round of the dose, right? So it is a overdose. No, we don't have to go for the overdose. Inadequate dosing, sometimes you have to supposed to take the 1 gram of we can say paracetamol and you are taking the 500 mg, right? So the dose is not adequate. Lack of current knowledge and training, yes. Most of the doctors, uh, yes, they don't know the current knowledge. As I said, they don't know even the basics of the microbiology and they are giving the random drugs. They are not being trained for how to prescribe the drugs, right? What are the symptoms and what drugs are related to specific symptoms, that only they have to provide, but they are failed to do so. So they are just giving the random drugs, and if you will be fine, it's good. If you are not, again they will do research on you. So that is their research, right? Okay, that we are giving such type of drugs and patient is it will be okay, then it's fine. In next patient they will do the same thing. So it's a research for them. You are the guinea pig for doctors, right? So yes, you don't allow doctors to play with your life, right? Strategy of contaminate. So how antibiotic resistance we can see develop? It is an evolutionary process. Exactly not. In earlier days, it was not evolution is not take place. It's like it can't be so fast, right? Evolution it can't be so fast. But yes, the faulty use of antibiotics, that is the main responsible reason for the antibiotic resistance. So there are two ways to get the faulty use of. If we solve the mystery, how we can solve this? So whether it is environment related or this is based on the hospital, right? So if we talk about the environmental, community acquired antibiotic resistance, yes, due to certain evaluation, but it's a very less chance, 5%, 10%. But yes, hospital acquired infections. So hospital acquired infections, definitely it will give you the antibiotic resistance. And if we can say the empirical use and definitive use, right? So use of antimicrobials before pathogen responsible for a particular illness or the susceptibility to a particular antimicrobial is known. Empirical use means yet you are not infected. In the simple example, you don't have the throat infection, but the precautionary use, doctor will prescribe you uh, in early times the azithromycin, right? You are yet not infected, right? But though you have used the azithromycin, right, that is the antibiotic, there are, your chances will be doubled, right? Or it will definitely get doubled, that you will be definitely infected. Or whenever the strain infect to your cells, there is no use of your azithromycin, because already you are exposed to that antibiotic. So your strain is already like mutated, and it doesn't have any type of effect, right? So definitive use means, okay, whenever you need that, just go for that time. Don't go for empirical use. So that is the main strategy to solve the antibiotic resistance, is you have to use antibiotic very precisely, very precisely, right? Poor clinical practice. Yes, we cannot go to the doctors and tell to the doctors that you are wrong. Obviously, we actually need their advice. But yes, if we are aware of antimicrobial resistance, and we are knowing the gravity of the antimicrobial resistance and what happened if we expose ourselves for this multi-drug resistance, then yes, we can obviously say, yes, we can obviously say that this malpractice should not be done. So poor clinical practice that fail to incorporate the pharmacological properties of antimicrobials amplify the speed of development of drug resistance. The same thing, that is a very hard language. I have said in the very layman language that we don't have to support to the doctors who are doing this business for their benefit, and they they have to save our life. They have to supposed to save our life using the very definitive use of antibiotic, not the empirical use of the antibiotic. So faulty antibiotic use, we must have to stop the faulty antibiotic use, and you have to dare, you have that dare, you should develop that dare to say no to your doctor, right? Because they are over prescribing you the drugs. Plenty of drugs in their prescription were there. You should go and ask them that what is this drug and it is used for what. Is it antibiotic? It is normal painkiller? It is just for the doctor is prescribing Rantec. Okay, this is for acidity. You should know what you are taking. Your body is not a dustbin. You can't throw anything into it, right? And yes, we don't have to take without prescription. First thing, first, what our fault is, we are taking it without prescription, right? Just like we are knowing everything, okay, we have to just take it. No, you can take paracetamol, you can take we can say Stopex, Ceridon, but yes, antibiotic, please don't do that. We don't play with your life. So two most criteria you have to follow about the antibiotic. And yes, I'm teaching you, you have to teach to others, to the layman public, to the people who in touch with you. They are not educated, right? Your relatives, your family, your friends, they are not from your field. You make them aware that you don't have to take the antibiotics without prescription. And if doctors are giving you, you have to just ask why and in what concentration you are prescribing us, right? So over prescription should not be there. Clinicians should first determine whether antimicrobial therapy is warranted for a given patient. So nowadays clinicians or doctors, they are not at all worried about the patient's health care. They are just close their eyes and randomly giving the antibiotics. So first they have to determine whether actually it is the need for that patient, that we should go for the, during this time, COVID times, I must say, all the people, they are suffering from only headache and only body ache, right? People, this Omicron symptoms, people are even not, they are, most of the 60% patients are not developing fever. They have just body ache and headache, right? So what we have to do, we have to just take the, we can say, some painkiller, right? Only the painkiller. But I asked many people, I asked many patients, in fact, COVID patients, and what you were taking? They gave me the long list. They were taking Dolo 650, they were taking azithromycin, they were taking vitamin C, they were taking zinc, they were taking vitamin D3, then what? Rentec, then some 2 3 more tablets. You know why there is this, doesn't need. And yes, doctors are prescribing so much, and they were testing about, they were telling that, oh, you should go for the CRP, you should go for the D dimer, get tested for certain blood reports, and get tested for RT-PCR. We need to understand that they are doing their bloody business, right? Lab lab people, they are doing their business, doctors are doing their business. But yes, what happened with our body, right? We don't have to give exposure to the azithromycin, to the Dolo 650. We are not having the fever, right? We are not having the throat infection, just normal body ache and headache, that's it. It will be covered within 2 or 3 days. Even I was suffered with the COVID last week, right? So we don't have to take all this antibiotics. So this is the latest example what I am giving you. Is antimicrobial agents indicated on the basis of clinical findings? First, we have to ask to the doctors that do you know what type of infection I'm suffering for? Okay. If you are knowing that what type of infection, if I am having the Klebsiella pneumoniae infection, I know the cholesterol will work. But do you know that I have Klebsiella pneumoniae infection? So first we have to ask the doctors. Or is it prudent to wait until such clinical findings become apparent? अगर आपको नहीं पता, if you don't know, then get tested, get my reports done, and then you have to find out the solution. Without any reports, without any investigation, you are not entitled to give me any type of drug, right? So empirical microbial selection. First, you have to select the microbes, that which microbe is responsible for your disease. Based on that, you have to treat that microbes only. You don't have to treat the broad spectrum of microbes, right? You cannot give the 10 medicine to the patients, right? That whatever the strain is there, it will be killed. No, we should not do like this. And why we are accepting this? So that is, I say, that is our fault, patient fault, right? That we are not knowing the things, we are not asking the things. We have to be very careful. So awareness should be there. Can some simple bedside test done to confirm your suspicion? Yes, obviously. Easily you can get to know within 2 or 3 hours that what type of infection is there. If you can't get to know, you can go for the culture. Within 2 3 days, you will get to know that what type of microbial infection are there, right? You can go for the microscopy. And gram staining is a, if you know the KOH method, it is a very quick method. Within 1 minute, I can say this gram negative or positive. You don't need to go for the gram staining procedure, right? If I'll meet you, then I will show you how KOH method will work for the gram staining. And within a 1 second or 30 seconds, I'll say that bacteria is gram positive or negative. That is a very quick method, right? Easily you can get to know. Have appropriate clinical specimen been obtained to establish a microbial diagnosis? First, the lab should be authentic, and appropriate clinical specimen, appropriate taste, all the standardization should be in proper form. So you will get the proper result, right? False negative or false positive result we are not getting. What are the likely etiological agents for the patient's illness? You need to take a history of yourself, that why I'm suffering from COVID. Okay, someone is there whom I met, and definitely, and what are the etiological factors, why, what are my different types of etiological factors, we can say, what are my personal history, what are my habits, you need to ask that tobacco chewing history is there or some comorbidity is there, so it will help you to treat positively. You should have all the data of the patients, right? Whether it is a personal, whether it is a genetic, whether it is a any type of secondary disorder are there or not. Is there clinical evidence from clinical trials that antimicrobial therapy will confer clinical benefit to the patient? Evidence-based medicine. Okay, you should know that if throat infection is there, azithromycin 500 mg can easily recover the patient. If you have evidence, yes, then only you can prescribe. Definitive treatment. Can a narrower spectrum agent be substitute for initial empiric drug? Yes. First, you will get tested. Okay, this patient, especially this patient, is having only such type of infection. The rest of the 4 patients, they doesn't have throat infection, so they don't need azithromycin. Only this patient is having the throat infection. Okay, so this will need the azithromycin, right? So you have to narrow down the spectrum. Means you that clinician has that narrow spectrum range, that what type of drug should be prescribed to the what type of patients. Not all the patients are demanding for azithromycin 500 mg. They will be just they will be cured using just only dolo 650, right? They don't need this type of drug. Is one agent or combination of agents necessary? Okay, sometimes what happens, some people are developing throat infections. Okay, you need to go for dolo 650 plus azithromycin, or sometimes you need some more antibiotics, right? Based on the condition of the patient. Say for example, different antibiotic, you can mix the different antibiotic, beta-lactam aminoglycosidase, then penicillin and beta-lactamase inhibitors, antitubercular regimen, antileprotic, cotrimazole, sulfadoxine, and certain types of combinational therapy for malaria or for certain viruses. So if we talk about the definitive treatment, means if we would like to go for the perfect treatment, the dose should be optimum, right? It should not be like we can say we cannot exceed the dose or the inadequate dose. It should be optimum. And route of administration, whether it is intramuscular or intravenous, and what type of duration of the therapy. If we say that 5 days course is required, why we should go for the 10 days, right? And it should not be like we can say 2 or 3 days course. It's not enough, right? It can relapse the disease. So duration of the therapy is most important factor. Specific tests to identify patients who will not respond to treatment. Okay, some of the patients, they will get development of resistance. They will not respond to this therapy, or we can say the antibiotic. So how you will taste, so antibiotic susceptibility taste, antibiotic resistant taste, MIC, minimal inhibitory concentration. There are different types of treatment should be there. What adjunctive measures can be undertaken to eradicate infections? We all know that vaccination is there, right? If we want to avoid the infection, just take the example of COVID. Vaccination is there. Yes, vaccination can't 100% prevent the disease, but it lower the efficacy, right? So whosoever vaccinated for 2 days, 2 doses, yes, they have very mild symptoms. They don't have to go to the hospitals, and mortality ratio. That's why in Omicron mortality ratio is very low, right? Steroid, you have to avoid the use of steroid, right? You have to maintain the pus means the bacteria secrete the certain metabolites that will accumulate into your body. So drainage of pus, you have to remove that pus from your lungs, from your body. So that system should be developed. Amputation and removal of catheter. all this thing, removal of catheter, because you have added catheter and everything, so it will create the infection. Again, you have to use the more antibiotics, right? So more and more antibiotic you will be used, you will get exposure of different types of antibiotics. So obviously you need to take care of the specific things. Yes, always I must say since long back that scientists and clinicians, if they are working together, then only we will come up with the solution of this antimicrobial resistance. But yes, I am very sad to say that clinician or physician, they are not ready to listen us. Never, right? So microbiologists, we will definitely go for all the type of testing, bacterial sensitivity, and find out, we will give them the solution, right? That this patient is having such type of infection, so you have to use this type of antibiotic. That we have idea. They have to just prescribe, right? They have to just treat. They have to just see the symptoms, whether they are improving or not, right? So we have to work together. So now, if it is balanced at par, then only we will come up with the solution, right? So we have to advise the proper and adequate antibiotics with balancing the economy of hospital. So pharmacologists, they have to prepare this, and physician, they have to just prescribe, and they have to manage the patient, right? We cannot manage the patient. We will just give them idea. Hospital acquired drug infection, that if somebody is admitted in the ICU, whenever it is admitted into ICU, it doesn't have any infection, right? He has some another problem, but after certain days, 10 days, 15 days, or a month, he develop a different types of strain and different types of infection, that is he or she would get from the hospitals ICU. So it's called the hospital acquired infection, and there is, we can say, we can't treat that infection because it is a hospital acquired mutated strain, and it has already developed the drug resistance. So it's called the hospital acquired drug resistance, right? So antibacterial policy should be there, that all the ICU and all the labs, and it should be like, we can say, fumigated, or sterile area should be sterile. Hospital anti biogram, hospital specific antibacterial resistant patent. Hospital staff and all the lab persons, scientists and doctors, they should know what is the antibiogram, what are the different types of bacteria are there, what are the different types of antibacterial resistance can come, right? They, all the knowledge should be there in the hospitals. And identification of potential pathogen most likely to cause infection. They should know that Klebsiella pneumonia is there in the ICU. So whatever the patients may enroll in the ICU, they have to take care of that patient, that this patient should not infected with the Klebsiella, right? So already they should know all these things. And audit, prescription auditing, prescription, whenever the doctor will give the prescription, it should be double checked, right, with the seniors. So hospital antibiotic policy should be there to curb the common misuse and overuse of antibiotic. They don't have to overuse the antibiotic, restrict the occurrence of antibacterial resistance, control the spread of such type of infection using the sterility. They have to maintain the sterility. So each and every hospital should have that antibiogram, right? It means the periodic summary of antimicrobial susceptibility of local bacterial isolates. They can culture the strain present in the ICU. They should have all the data, which type of antibiotic can be used against our hospital acquired strain. So these are the treatment for different organism. Say for example, S pneumoniae, right? So penicillin G, it has the resistant, right? But antibiotic we can use this ceftriaxone, right? And vancomycin plus rifamycin. So this is the combinational therapy. So different organism, different resistance are there, and antibiotic we can use for this. You can see for E. coli, but mostly Klebsiella pneumonia, that is the hospital acquired infection, and this P. aeruginosa and E. coli. So these are the list of gram positive bacteria, right? And we can see the for gram positive bacteria, first line antibiotic, we can use this. And if we get the resistance from penicillin, then we can go for the vancomycin, right? Oxacillin, ofloxacin, right? So this is the first line and secondary line antibiotic we can use from gram positive bacteria as well gram negative. So list is there, hospital acquired infection list is there. For hospital acquired the drug for hospital acquired infection antibiogram is there. Here you can see all the drugs recommended for different types of disease, right? In all the hospitals. So they should have their charts. They should have their, we can say plan A, plan B, plan C. Plan A will work, not work. Plan B should be there. Plan B will not work. Plan C should be there. So what is the take home message? So first we have to go for the definitive therapy of known pathogen. Means we don't have to take random drugs. Treat infection, not contamination. We have to treat infection. Then know when to say no to the vancomycin. Yes, I always say you have to say no to the doctors, right? First, you need to go for this specific tasting. You have to isolate the pathogen. You have to see you need to check your report. Okay, I'm getting such type of infection. You are microbiologist. You should know that this drug will be treat my disease, right? So start simple bedside test, gram staining, microscopy, you will get all. Okay, so all the best to combat the drug resistant, multi-drug resistant, antimicrobial resistance, right? So we have to be first aware, and then we have to make others aware about the multi-drug resistance, right? We have to appreciate the awareness, patient awareness program. We have to motivate, and if you student can make such type of program, we will definitely help you. We will provide you the information. We will arrange such type of program for you, right? Okay, so I think it will be over. Yeah. So in the next lecture, we will go ahead. And you can use this. I will upload this lecture on the YouTube. You can always use this. Okay. So next lecture is on Wednesday, I think. Right? Wednesday, 12:20. Okay, guys. Have a nice day. Bye. Yes, Devi, your question is there. Does a prolonged use of antibiotic for chronic disease subject us to developing? Yes, you cannot use prolonged, right? Yes, it will develop the resistance. Thank you so much for asking the question.